We will start with the second speaker, Dr. Krishna Prasad Kudlu. He needs no introduction, and he is from Karnataka, a very high volume, especially refractive surgeon and anterior segment surgery. So he is going to speak on Know Your Biometry.
Thank you, sir. Respected chairperson. So I'll be talking about Know Your Biometry. No financial disclosure for this particular talk. Just for the introduction, measuring various dimensions of the eye, its components and their interrelationships, and using this data to determine the ideal intraocular lens power. Basically, biometry consists of keratometry reading and the axial length of the eye. So if you go to any of the literature, probably claims relating to the biometric error or wrong IOL power were almost second most frequent cause of claims and result in payment damage of almost 62% of the closed cases. So coming to the keratometry, basically it is used to measure the corneal curvature. We have to do before axial length measurement. There are two types of keratometer. One is manual keratometer, auto keratometer, and also with the help of topography, either with the placido disc or elevation based, you can know the keratometry. So manual keratometry, two principles, basically fixed object and variable image size, and also with the fixed image and the variable object size. Coming to the automated keratometer, most of us using this, the principle is it focuses the reflected corneal image from the central 3 mm zone onto an electronic photosensitive device which instantly records the size and computes the central 3 mm zone of radius of curvature. So coming to the axial lens measurement, there are two types you can measure. One is with the optical and one with the ultrasound. So coming to the basic principle of ultrasound scan, it has got a piezoelectric crystal that electrically emits and receives the high frequency sound wave. Normally, it measures from the anterior corneal surface to the internal limiting membrane of the retina. If you make a 1 mm error, that means it's almost like 2.5 diopters of error in the postoperative refraction. So, to tip for accurate measurement of the axial length, always make sure that machine has to be calibrated very well. Always you should look for the echoes from the cornea, anterior and posterior lens, and also retina should be present in the very good amplitude. Always you should take minimum of 5 to 10 readings is very, very important. So there are difficult situations where you may have a gain, that is especially in case of you have to increase the gain in case of dense cataract, or you may have to decrease the gain in case of silicon filled eyes and also in the pseudophakic eyes. To do a better results with the ultrasound, we have got a immersion technique where it can be normally patient has to be lie down or can be performed in the standard ophthalmic chair which is reclined at 45 degree using either Oceaning or Prager cell. But it takes some more time for this one. There are few, I think, condition where you may have a inadequate fixation like low vision, nystagmus, strabismus. So coming to the one or two word about the posterior staphyloma, it causes a irregular shape of the ocular wall. So you may find a little difficult to get the axial length exactly. Coming to the silicon oil, because in the silicon oil, this low sound velocity can result in pronounced sound attenuation, and sometimes you may find very difficulty to find a retinal spike. So coming to my talk today about the how this has been grown from 500 to 700. Basically, it works on the different parameters, this first source biometry. So normally this IOL Master 500 works on the partial coherence interferometry. Coming with the IOL Master 700, it normally works on the first source biometry. So it do almost 2000 scans per second. So it works on these parameters, very, very important. You take into account of axial length, anterior chamber depth, lens thickness, central corneal thickness, very important white to white, keratometry, and someone who got a cataract size suit, it can even guide for a markerless system with the Callisto. So very important is pupillometry also, it even know the pupillometry. So this is about the specification, I will not talk much about this, but very important, as I said, that 7 parameters: axial length, central corneal power, lens thickness, AC depth, white to white, age of the patient, it takes age of the patient and also very important previous refraction. So this how it gives, if you see the foveal pit in green, this one, that means there is a good fixation, but if there is, you cannot see the foveal pit, that means there is a poor fixation. So I'll just show you how exactly, if you see with a good fixation, see for the, always see for the foveal pit. And there is a only difference of, if you see the axial length measurement, only difference of 10 micron difference in the axial length, and only 0.02 diopter difference in the keratometry. This you have to always look into that. If you see here, there is a poor fixation, no foveal pit. That means there is already more than 190 micron difference in the axial length and more than 0.5 diopter difference in the keratometry. That means these readings are not accurate. Not only doing the scanning is important, you need to look at the every parameters. So now the thing is, most of the patient comes with the post-refractive surgery. Normally, if you got, this has got a fully integrated Barrett suit, so with that you can get into the all the formulas and the results are going to be very, very accurate. So the one more advantage of this machine, if you see here mature cataract, white intumescent cataract, even 99% of the cataract it can penetrate very well. Even if you think about doing a premium surgery with of in a mature cataract, that really gives a more accurate results. And you can give a indication for macular pathology. You can just refer to the retina surgeon for a further evaluation. Overall outcome of the results is going to be the best. You can even pick up something like diagnose like macular pucker. This is very, very important, especially even though this machine is for anter-segmental cataract surgery, it could be able to pick up some of the retinal condition. And all 4 generation formulas are also there in this, from Holiday 1, Hoffer Q, SRKT, Hegisen, Holiday 2 Barrett's, all incorporated into this. So then one more thing is, it is also very good for the toric IOL power calculation. So this is about the how exactly it do. See, if you see like less than 45 seconds, both the measurement will be done, and you need to always look for how exactly it does. Even with the green tick, then it measures the, it takes the points into consideration. Immediately if the readings will come. So less than 45 seconds for both the eyes. So when you are doing, also ask the patient to see straight. Always whenever I am doing my premium surgery, I always look at the, even look at the dry eye status and then go ahead with the results. So coming to the workflow, even I do have got a cataract markerless system. With the toric workflow, you can, the data can transfer from the IOL Master 700 to the Callisto eye. So these are few limitations with the dense cataract. Sometimes you may find little difficulty in this, but it's also expensive. In summary, overall it get a fewer, very less refractive surprise. It improves your refractive outcome and optimize your workflow. In conclusion, due diligence has to be undertaken during the biometry to prevent post-operative refractive surprises. A proper history, use of optical biometry and also specific formula is utmost importance. In customization of the cataract surgery, biometry is primary. Thank you one and all for the opportunity.
So in toric cases also you use this machine.
Yeah.
The Barrett toric formula you are
Yeah.
seeing. So what difference did you find with these machines? You said the lens thickness also it can
Yeah.
be seen. So do you keep changing the IOL power calculation whenever there is an intumescent cataract with the antechamber depth is low in this eye and other eye antechamber depth is more? So do you take the exact calculation what the machine gives, or you keep
No, I
changing
take the exact calculation whatever the machine gives. But seeing the lens thickness, it will be more useful when you are doing phaco. Because see, if you think that the lens thickness is very thick, then you may have to normally, I see the AC depth also. AC depth is shallow and less thickness is more. Normally, I take a more preventive measures like taking a high viscoelastic while doing the phaco. That gives the more result. But I will not be changing any of the parameters as far as the result is concerned.
So this is the problem. What happens in the IOL Master 700 is the intumescent cataract, it effective lens position, it calculates as if the lens is much anterior. But after the surgery, the lens goes
That
back
is the
and
one
then,
thing.
yeah, the patient goes into hyperope. So we need to,
That is the one thing, effective lens position, you have to also keep it in mind.
yeah, thank you, Kudlu.
Thank you.